Rhonda Whiteman is our presenter today, who's going to provide an update to the Canadian Stroke Acute best practices. I said that wrong. Okay, I want to welcome Rhonda Whiteman, our presenter. She is the Stroke Best Practices Clinical Nurse Specialist at Hamilton Health Sciences. She supports team within Hamilton Health Sciences and the Central South Ontario Stroke Network to implement best practices for stroke care across the continuum. Rhonda completed her Master's of Nursing from the University of Toronto in 2008 and her Bachelor of Science in Nursing from McMaster University in 1989. She has maintained her Canadian Nurses certification in neuroscience nursing since 1994. She holds a part-time assistant clinical professor in the School of Nursing at the Faculty of Health Sciences at McMaster University. She has presented a number of papers at regional, provincial, and national conferences over her 35-year career in neurosciences. Welcome, Rhonda.
Thanks, Tina. I'm going to provide an overview of the Canadian Acute Stroke Best Practices Update that were last updated in December of 2022. Before I start, I really like to just do a bit of framing on the impact of stroke in Canada. A study in 2017 revealed that there are over almost 110,000 new strokes occurring each year in Canada. And it is known that there are approximately 878,000 Canadians living with stroke. Every 5 minutes in Canada, somebody has a stroke. It is the leading cause of adult disability. And so all of our efforts, when we look at hyperacute stroke care, timely access to treatment, we are looking to decrease our prevention services, our acute stroke care, our stroke rehabilitation, are to decrease the disability after stroke. It is also the third leading cause of death in Canada. And we know that stroke doubles every year over the age of 65. However, we are seeing an increase in strokes in the young. And what do we mean by younger adults? Those in the 20s to 59. So really, my message is stroke can happen to anyone at any time. And we are expecting to see the risk of stroke doubling in this younger age group as we move forward. The other thing we know is having stroke more than doubles the risk of developing dementia. Almost half of Canadians who have been touched by stroke, either experiencing that themselves or by having a close family member or friend who's had a stroke. We also know for each clinically evident stroke, there are as many as 9 covert strokes, so strokes where there's damage to the brain that result in cognitive impairment. We also know that once somebody has a TIA or stroke, they have a 20% chance of having a second stroke within 2 years. This raises the concern and the need for very aggressive secondary stroke prevention. So when we look at the 2022 Canadian Stroke Acute Best Practices, you'll see that there are 2 phases of care that are covered by this. So there is the pre-hospital and emergency department acute stroke care, and that typically is looking at that first 24 hours and the hyperacute time-sensitive window. And then the acute stroke care, so the discharge from acute to the first 30 days. We're going to really just focus on those in the pre-hospital and emergency department acute stroke care, really focusing on 6 key best practices in that area, and we'll walk through each of those. So when we look at stroke awareness, recognition, and response, really, Ontario was the first province to organize stroke care in Canada. In 2000, the Ontario Stroke System was developed. It was developed into a system of regional networks that were developed for stroke care delivery across Ontario, and to provide rapid access to emergency stroke management was a key element of this. Part of this provincial system was working with the base hospital medical directors, the provincial medical advisory committee, and the emergency health services branch of the ministry to create the provincial paramedic prompt card and the acute stroke protocol. The provincial paramedic prompt card has been around since the early 2000s and has been updated periodically as the evidence has changed in best practices, and also as we've seen changes moving forward. And so certainly with the introduction and changing of the thrombolysis window, we saw changes to the prompt card. With the introduction of endovascular therapy and also the expansion of the endovascular window. And so you'll see then with the addition of the LAMs. We have the Central South Regional Stroke Network has worked very closely with the base hospital program and the paramedic services in our region to implement the Central South Regional Stroke System Memorandum of Understanding for Acute Stroke Bypass and Redirect since 2016. And so really you can see in our region that we do have an organized system of care that really establishes that rapid response. The other key point of stroke awareness is that education that stroke is a medical emergency that can affect persons of any age, newborns, children, and adults. What we know is 1 in 6,300 babies are born with stroke. This is one each week. In Canada, there are more than 10,000 children ages 0 to 18 living with stroke. So really, stroke can happen to anyone at any time. There's been a significant focus on awareness campaigns to recognize and react to the signs and symptoms of stroke, focusing on the fast signs. One of the things that you will see within the Central South Network is on our ambulances. We have partnered to have the fast warning signs to really have individuals recognize to increase the awareness of symptoms. We know that knowledge of the signs and symptoms of stroke is still quite poor, where about 11% could not identify one symptom of stroke. 65% can identify 4 of the 6. We continue to do the Central South Regional Stroke Network, do multimedia modal public awareness campaigns in June for June Stroke Month and in October for World Stroke Day on October the 29th to really get that message out about recognition and reaction of stroke. When we look at the next best practice, it's triage and initial diagnosis, evaluation of TIA and non-disabling strokes. We know TIA and minor strokes are unstable conditions that can be at higher risk for recurrent strokes. Risk of recurrent stroke is reported to be almost 5% within 90 days, with that risk being upfront loaded within the first few days of about 4%. The 7-day risk of stroke following TIA can be as high as 36% in patients with multiple risk factors. Timely initiation of secondary prevention medical treatment and carotid revascularization has been shown to reduce the risk of major stroke and TIA after that initial TIA and non-disabling strokes. So we know individuals who experience signs and symptoms of acute stroke require rapid assessment, diagnosis, and determining their risk for recurrent strokes. Patients who are diagnosed with TIA or minor ischemic stroke are not candidates for acute stroke treatment, but should be prioritized for secondary prevention of stroke assessment and management. Patients who present within onset of symptoms less than 4.5 hours, regardless of whether their symptoms have resolved or not, should be seen for urgent assessment. Patients with onset of symptoms between 4.5 and 8 hours, regardless of when the symptoms have resolved, should be referred for urgent assessment. Patients who present to outpatient settings, so to urgent care, to their family physicians, should undergo evaluation by a healthcare provider with stroke expertise to determine recurrent risk. What we also know is after 48 hours, those patients also need a comprehensive evaluation and brain imaging as soon as possible. We have stroke prevention clinics across our region linked to all of our acute stroke sites. So in Grand River, in Brantford, with a satellite in Norfolk, in Niagara, in also at Joseph Brant at the Hamilton General. The stroke prevention clinics provide rapid access to stroke experts, investigations, risk factor management. We know patients who have vertebral basilar ischemia, so diplopia, dysarthria, dysphagia, ataxia, vertigo, may occur for greater onset than 48 hours. These may be mistaken as stroke mimics, but still need urgent evaluation and brain imaging. And certainly Dr. Sarasta will talk more about this in his assessments. When we look at the emergency management of acute stroke patients, what we know, this covers the pre-hospital phase, the emergency department phase, and also inter-hospital transfer time. What we know is about 2/3 of patients who seek acute care for stroke arrive by ED by ambulance. In Central South, we know the range of that is between 60 to 75% arrive at our acute stroke hospitals by ambulance. When we look at these three phases, typically the pre-hospital phase is looking at that 0 to 6 hour phase. The emergency department phase is that transition to the emergency department. And those inter-hospital phase is transfer from one hospital to another for more advanced stroke care. So going in a bit more detail, really the components of this emergency medical management, as you can see, looks at accessing medical services, paramedic on-scene management, transport of suspected stroke patients, and that handover in the ED. So we know there is a very coordinated and comprehensive system where when a patient calls 911, dispatch will ask a number of standardized questions to really determine if that patient's having a stroke. The ambulance communication centers will collect that information and dispatch and communicate that to the paramedics. We know that our paramedics use the provincial paramedic prompt card for that pre-hospital stroke screening. We also know that the paramedics utilize the LAMS, the Los Angeles Motor Scale, for that screening for the large vessel occlusion on scene, that there's limited of treatment on scene to those that are immediately needed. And so really that load and go philosophy that all of you utilize. Really crucial is getting a very comprehensive history from the witness, and also if possible, getting a phone number so that the neurologist can have that conversation with the witness when the patient arrives, minimizing to keep that on-scene time less than 20 minutes. Also doing a capillary while the patient's en route. And also, as I said, really instructing the family or the visitors to really be accessible either to the hospital in person or by phone. And ideally, if you can get a mechanism or a number to reach them, that is also very helpful. When we look at transport of suspected stroke patients, we know that we have direct transport protocols to ensure patients in our bypass protocols get to the acute stroke hospitals. Patients are triaged as a CTAS 2 or a CTAS 1 if their ABCs are compromised. There is a pre-notification patch to the ED, which includes last known well, stroke symptom onset, LAMS, and ETA to the hospital. We know patients outside of the 6-hour window are transported to the closest hospital. And we know that there are processes for rapid transport to facilitate patients who may be a clot retrieval or need access walk-in protocols to get them transferred to the closest hospital that can provide that time-sensitive stroke care. The last phase of the emergency management is really that handover in the ED and really providing that rapid transfer of accountability for patients within the window and having that highest triage time, really giving that comprehensive TOA in the emergency department to help facilitate decision-making. So onset or last known well time, looking at their current symptoms, Were they improved? Have they changed since they were picked up in the field? Looking at their current status. If there's a LAMS, what is their severity score? Looking at their, medical stability, what was their current functional abilities and baseline and independence level? What is their current meds, if known, especially if they have on anticoagulants? If they are, did they take their anticoagulants? And if so, when? Are there any advanced medical care directives, advanced care plans in place that we need to know about, and any additional health concerns? Essentially, really what you can see and why I've just illustrated is our prompt card really covers all of the sort of emergency phases of care and those pre-phases and that handover that happens. Some of you may be familiar and have heard of mobile stroke units either from the US or in parts of Canada. Mobile stroke units are ambulances that have a CT scanner on board that can do a CT head and a CT angiogram. They may also have a stroke nurse or a nurse practitioner, a neurologist, a stroke fellow on board, or the ability to link via video conferencing, similar to telestroke, to a neurologist at a stroke center. Patients will undergo a CTA in the ambulance. They will link with the neurologist to review the images, and they can make decision making regarding giving thrombolysis, and it can be given in the ambulance even prior to arrival to the hospital, and can also make decisions about eligibility for endovascular treatment. So allows, for example, if the patient's between a primary stroke center or a thrombolysis site, but not an EVT site, and an EVT site to determine do they go directly to the EVT center. This has been implemented in rural and remote areas in Alberta and in the US and many large urban cities. Sometimes the stroke ambulance can meet regular ambulances and do the imaging, make treatment decisions, and determine to transport to the stroke center, or if not, have them be transported by the regular ambulance to the closest hospital. Unfortunately, the Canadian Stroke Best Practice recommendations could not make any formal recommendations about mobile stroke units because the published data in the Canadian context and healthcare system is lacking. There is some high quality studies in other countries that would suggest the use of mobile stroke units is associated with a reduced time from symptom onset to thrombolysis, increased proportion of patients receiving thrombolysis, and better functional outcomes at 90 days. So more to hear. We may see changes in the best practices related to this in the future. When we look at the emergency department evaluation and management of TIA and acute stroke, certainly you'll see that there's that immediate assessment and determining diagnostic investigations to determine eligibility for hyperacute treatment, rapid neurological evaluation and assessment of vital signs, acute stroke blood work, and imaging. What you will see in the 6-hour window is that the neurovascular imaging that we utilize is twofold. One, it's a non-contrast CT head, which is the first-line diagnostic tool for all patients with suggested neurological impairment. What the physicians are looking for is areas of bleeding or infarction in the brain. It really assesses the eligibility for, it determines eligibility for stroke thrombolysis. Multi-phase CT angiogram helps to determine what it is it's a CT scan that looks at the arteries of the neck from the arch of the aorta up to the brain. So looks at the internal carotid arteries, the posterior cerebral circulation, looks at the circle of Willis and the cerebral arteries. What it allows us to do is, one, identify if there is any large vessel clot in one of the large vessels of the brain. Also, we'll pick up if there's carotid stenosis, if there's plaque or free-floating clots in the brain, carotid dissection. It also will help us to evaluate collateral blood supply of the brain. It is does require IV contrast, and so does require a large bore IV. Ideally, because we're looking at a large bore IV, it's great if you're inserting an IV in the field, if you can do it in one of the antecubials, avoiding the hand if possible, but really focusing on getting the largest bore IV if you're inserting that in the field. When we look at neurovascular imaging in the 6 to 24-hour window, what we know is endovascular therapy is appropriate for patients in the 6 to 24-hour window, including patients stroke on awakening or with unknown onset, may potentially be eligible for endovascular treatment. Patients should undergo a CT of their head, a CT angiogram, and a CT perfusion. What you see on the right of my screen here is one of the outputs that we see from a CT perfusion. The CT perfusion assesses the cerebral blood flow to identify areas of significant reduced blood flow in acute ischemic stroke. It creates easy to interpret maps which quantifies that blood flow using color coding and volumes to determine patients eligible for EVT. So in this example, you can see the pink areas here are areas of the brain which have significantly reduced blood flow in the brain. What you though see is the green areas are areas where there is reduced blood flow, but blood flow is not significantly reduced. This area would represent an area of salvageable brain. CT perfusions also require IV contrast and so require a large bore IV. What we know when we look at acute ischemic stroke treatment is all stroke patients with disabling stroke symptoms within 6 hours of last known well should be screened without delay by a physician with stroke expertise to determine their eligibility for IV thrombolysis or interventional treatment with EVT. Patients presenting within 6 to 24 hours should be rapidly screened to determine eligibility for advanced imaging and acute stroke treatment. All of the trials that are done picked up and used, determined it in patients who were functionally independent at baseline. The use of thrombolysis and endovascular treatment in patients that are not functionally independent at baseline should be done weighing the risks and benefits for the patient. When we look at IV thrombolysis administration, you will see some changes to this in this version of the Canadian best practices. All eligible patients with disabling strokes can receive IV thrombolysis with alteplase or TPA or tenecteplase TNK within 4.5 hours of last known well. Tenecteplase may be considered an alternative to alteplase within 4.5 hours. It is a single bolus dose, 0.25 milligrams per kilogram to a maximum of 25 milligrams. Tenecteplase for acute ischemic stroke is half of the cardiac dose. We know time is still brain, and so the median door to needle time is a target of less than 30 minutes, with the 90th percentile should receive their door to needle in less than 60 minutes. So you may say, well, why? Why did we switch to tenecteplase from alteplase? A Canadian multi-center trial of over 22 stroke centers was done that looked at randomizing patients 1-to-1 in 1,600 patients to test if IV tenecteplase compared to IV alteplase was non-inferior in patients with acute ischemic stroke otherwise eligible for IV thrombolysis. So what they found is tenecteplase is non-inferior to alteplase. So essentially what that means is equivalent to alteplase in terms of functional outcomes and risks of complications. What they found is patients who received tenecteplase, 37% were functionally independent at 90 days versus 35% in the TPA group. The risk of symptomatic intracranial hemorrhage in the brain was equivalent in both groups at 3.4%. Systemic hemorrhage was rare in both groups, less than 1%. And angioedema are rare, but serious airway compromise is rare, less than 1% of angioedema. So you may wonder, why would we switch to tenecteplase from alteplase? It is so much easier to administer. It's a one-time bolus administered over 1 minute, over 5 minutes, versus TPA is a bolus followed by an infusion over an hour. There's no infusion pump. There's much more simplified dosing. It's less likelihood for dosing errors. You will see in our region, 3 of our sites have already moved to tenecteplase from alteplase. So the Hamilton General went live in January, Grand River went live in February, and Guelph General went live in June. We anticipate Niagara Health, the Greater Niagara site, will go live shortly in the next few weeks, likely in October, September, October. And then Brantford and Joseph Brant will be likely be near the end of the year or into the new year that they'll be making that switch. So when we move on to endovascular therapy, what we're looking at is large artery occlusions. And when we talk about large artery occlusions, we're talking about occlusions or clots in the internal carotid artery, the middle cerebral artery, or the basilar artery. Anterior circulation strokes would be in the internal carotid, the middle cerebral artery. Patients should be considered based on their premorbid function, their clinical deficit imaging finding, and patients within 6 hours should be treated, should receive EVT. Selected patients within the 24-hour window may be treated depending on advanced imaging. Posterior circulation strokes, so strokes, an occlusion in the basilar arteries, should be treated based on the patient's status, their imaging, and imaging findings. What we know, and just a reminder when we talk about endovascular treatment, if we look at the top is medical treatment, so thrombolysis, but no EVT. Large vessel occlusions are our most severe strokes. We know with just IV thrombolysis, only 29% would be independent, 52% were left with disability, and 19% would die as a result of their stroke. When we look at endovascular treatment, patients who undergo endovascular treatment, 53% or an additional 24% were independent after stroke. There was a decreased disability by 15% and decreased the risk of death by 10%. The number needed to treat to have one patient be independent with endovascular therapy is 4. That's a very powerful medicine, very powerful number needed to treat in medicine, with the risk of bleeding, as we said, only is about 3%. So what we'll do is that really summarizes what we're looking at for the acute Canadian Stroke Best Practices Update for 2020. Thank you.